There's been a slight change in schedule, and we will be having our next talk titled Secondary Hospital Postings and its Role in Providing Equitable Healthcare by Dr. Emmanuel Lazarus. And I invite Dr. Ramya to moderate the session.
A very good morning to all of you. Um, it gives me great pleasure to introduce Dr. Emmanuel Lazarus. Dr. Emmanuel Lazarus is working as an assistant professor in the Department of Surgery, Christian Medical College, Vellore. He has completed his MBBS and MS from this institution. He is the coordinator for the secondary hospital program, which sends medical students to the mission hospitals where they get a flavor of the hospital. And this he has been doing it for the past 3 years. So he has got a great experience in this field. And also he is the coordinator for the district rural program for the postgraduates. So Dr. Emmanuel is keenly interested in linking the students with the secondary level hospitals, and he will tell us what he has been doing for the past so many years. Dr. Emmanuel.
Thank you. Thank you, Professor Anand, Dr. Ramya, and several others for having me here. It's been wonderful to be here, and it's been a fantastic experience listening to such enlightening presentations all morning. Thank you again for letting me be a part of this. Good afternoon. My name is Emmanuel. I work in the Department of General and Head and Neck Surgery. I know this is pre-lunch, so in the interest of time and our appetites, this will be short. I will not profess to be an expert in this matter, and I'm only one member of a much larger team that has been looking at the secondary hospital program for the last 40 or 50 years. So I'm just one small cog in the wheel. But I will share with you what I found interesting and what continues to strike us every day. There is a lack of equity in healthcare, and that's a given. If not so, this conference would be irrelevant. But I'm going to show you a slide which is particularly interesting. This is a slide that looks at the 5-year mortality for different causes. And you can see on one end is the 5-year mortality for lung cancer is nearly 80%. There's some for breast cancer on the extreme left, Charcot disease, diabetic foot ulcers, minor amputations, limb-threatening ischemias, and major amputations. And it's interesting to note that the 5-year mortality for somebody who's had a major amputation is much worse than all cancer. Only lung cancer beats that. It's not a statistic that I would expect. The 5-year mortality for breast cancer is about 9%. It's about nearly 655 to 60% for someone with a major amputation. And the 5-year mortality for somebody who just has a diabetic foot ulcer is comparable to all cancer. Not a statistic that I expected. Even in Vellore, even in CMC, if I have a patient who comes to me with breast cancer and doesn't have money, I have plenty of resources that I can tap into. She can be a part of a program. I can put her into a trial. I have funds to draw on, institutional, governmental. It's very unlikely she's going to go away without treatment. But if I have a patient who comes to me with a foot ulcer, and many of these patients do come with a foot ulcer, an acute sepsis requiring an amputation, my hands are tied. There isn't enough that I can do. And that really is the reality of the situation we live in. The fact is that inequity, even in healthcare delivery, is woven tightly into the fabric of our system. But I'm not here going to talk about how bad it is or how effective it is. I'm just going to tell you of what we try and do to fight against this problem. So I'm going to show you another interesting slide. So this is published by Sabde and others in BMC. And this looks at the distribution of medical colleges across the country. And if you look at the map, it's quite evident that most medical colleges, and as I'm sure you will know from experience, are centered around cities or in major provincial urban areas. It's interesting that even the new medical colleges that sprout are often, about 70% of them are within 20 to 30 kilometers of an existing medical college. So at the forefront of this fight against inequity, at the front lines, is the junior most medical doctor. It's not the politician, it's not the policy maker or somebody leading a think tank. It's that junior most medical doctor fresh out of medical school. And this product of modern medical education, in all probability, has come from one of these large tertiary referral centers in urban India. And he's going to be far removed from the realities that most patients face. And that really is a truth that we have to come to terms with. The quality of doctors as effective drivers of equitable care is greatly determined by the systems they are molded in. And the foundations of equitable healthcare have to be laid down early and deep during undergraduate and postgraduate. Forget postgraduate. I would say undergraduate medical education, because if we are to fight against this problem with any amount of success, that is where we have to strike. You cannot fight against what you don't know. If you have never had an ice cream in your life, I can go into raptures about how wonderful it is on a summer's afternoon. But if you've never had it, no amount of lecturing can ever communicate it to you unless you have it for yourself. So similarly, no amount of descriptive didactic lectures that tell you, oh, look, there's inequity, there's the poverty rate is this much, and there's lack of healthcare. It's not going to come across unless you live it for yourself. Can empathy be taught? I'll ask you, can empathy be taught? I really don't know. But we believe that by immersing medical students directly in the circumstances that underserved communities face, these experiences may, we hope, act as catalysts that drive lasting change. So our exposure, our approach to ensure exposure during medical training has been knitted into the curriculum at CMC for decades. And this started with the community orientation program as early as 1976. So this is a unique program where students at the end of the first year, that is at the end of Anat, Physio and Biochem, spend an entire month living in the village, in a village near Vellore. And this is not a casual cursory visit where you see, poverty, lack of access to health. Can you go home to your comfortable life? You stay in the village every single day and you experience and visualize the hardships and the inequity that they face every single day. It's one thing knowing that the nearest hospital is 3 kilometers away, but actually walking those 3 kilometers in the unforgiving Vellore sun, as I found out to my disdain when I was doing my COP, is a totally different issue in itself. And on that road, when you're walking with the sweat trickling down your face, and you see an old man with a foot ulcer hobbling along with his dressing, shabbily walking in the dust on an untarred road in the hot summer heat, and you reach that hospital ahead of him, and then he comes to you for a dressing change, you will think 10 times before asking him, why is your dressing so dirty? And that is really what we hope to convey by these programs, by making sure that these lived experiences last with the students. Experience nails perspective deeper than any PowerPoint lecture can. And yes, the COP program does talk about epidemiological fieldwork and the basics of community health and statistical analysis and sample sizes, yes. But this early medical career exposure has been, for many of us, the tool with which the scales have fallen from our eyes. Now that the groundwork has been laid, in the subsequent year, we conduct the secondary hospital posting, or the SHP one. And this is a program that began in CMC with the batch of, I think, 1988. Correct me if I'm wrong. And a little bit about the history of the story is appropriate. All through CMC's history, newly graduated doctors post-internship serve at different rural mission hospitals in areas of need across the country. And this has been going on since the inception of medical training in Vellore. Now, in the late 80s, with the batch of 1988, it was felt that perhaps it would be useful for these students to visit these hospitals a little earlier during their medical training itself, to get an idea of the center that they would be going to during their service obligation. And this is what we call the parent hospital program. And over the next 5 years, this transformed into a structured program, which is what we know now as the secondary hospital program, where rather than just going to their parent mission hospital, students would go in groups of 5 or 6 to different secondary hospital settings across the breadth of the country in areas of need, and often accompanied by a faculty member, and they would experience firsthand the challenges of providing healthcare in these locations. And these locations were not arbitrarily chosen. They were chosen carefully to look for areas where hospitals had a track of delivering affordable and accessible quality care in resource constrained environments. Many of them are part of the Mission Hospital network. Many are not. The Rural Development Trust Hospital in Anantapur, the Gudlur Adivasi Hospital, among several others. So I'm just going to show you um, what we do. So this is a structured 2-week posting that is an integral part of the curriculum as part of their official training. So there is a debrief before they go. There is a faculty who goes along with them. There is a logbook that they fill that is graded. There are clinical case workups. They're guided by the faculty accompanying them with a focus on clinical social aspects. They engage in lab work and participate in community outreach programs. They interview faculty at these hospitals, delving deep firsthand. What drives them to work in a center like this? Why did they choose to work there? How are they coping? How are they balancing academic research in a setting like this? Are they disappointed? How are they coping? What are their strategies? And these are the stories that really inspire. There is two-directional feedback as well. So the faculty tell them about their experience with them, and they give them feedback to the students on their performance. The students also give feedback to the hospitals as well. What would they want in a hospital if they were to go and choose to work in a center like this? And when they return, they all present an essay on their experience. The groups present a formal discussion with faculty and administration, facilitating collective discussion. And this process is sort of repeated during the second year, during the third year as well as part of SHP2. And while SHP1 is more clinical, social, and community outreach oriented, SHP2 is more dealing with clinical cases and focusing more on management of clinical problems. How would you provide cost-effective quality care without compromising outcomes? How will you reconcile guidelines which call for expensive plans and evaluation that cost more than that patient's annual income? And these are the challenges that they have to grapple with when they go there. After final year and internship, they move on for 2 years in their secondary hospital for their 2 years of service obligation, where they can put into practice all that they have learned, rooted in the context of where they serve. From 2017, a similar program was initiated for postgraduates, also placing them in high volume centers that was similar to their stream. And as you all know, I'm sure that over the last 2-3 years or so, and probably implemented from this year onwards, is the district residency program that the NMC has instituted, which mandates that all registrars in broad specialties have to spend 3 months in a secondary hospital program. And we're very happy because this is something that we've been harping on for more than 50 years because it's that important. And we're very happy that this has become a pan-India thing. The benefits of having a secondary hospital program is threefold. First is the fact that we believe that only early sustained exposure can sensitize students to the complex problems that underserved communities face. And this potentially fosters an early commitment to deliver equitable care as doctors. You cannot deliver equitable care if you do not know what inequity feels like. And this is what we want them to know. Secondly, students who have had exposure in areas of need are more likely to choose or opt to work in centers which require help. And thirdly, the lessons that we learn act as templates for others also to collaborate and build on, for other programs, undergraduate and postgraduates to build on. The aim of the SHP program is not to make every doctor a secondary hospital doctor. If that is the case, then by every metric, it's a failed system. But the aim is so that we can create early exposure, and this early understanding can tackle the problems that plague healthcare delivery every single step of the day. I keep saying this again, you cannot fight what you have not seen. And I will show you a picture of okay, so this is just an overview of what happens to a student who has started in CMC. So he starts with a community orientation program. He spends a month there. In second year, he goes to the SHP1 program. In the third year, he goes to the SHP2 program. So by the end of internship, he has not had a single moment where the problems that face healthcare has not been uh, uh, driven deeply into his mind, not by a didactic lecture, but because it's his lived experience. Then after his internship, he spends 2 years in a mission hospital or in a service obligation network. And then thankfully now with this year onwards, we have 3 months as a postgraduate. So hopefully in time, this will expand and act as one more tool against the problem of inequity. This is a picture of, what is this? This is a picture of a plague doctor in the early part of this millennia, and you can see, you have an idea of what they wore, and you can see that they were supposed to wear a bird mask of sort, and they would fill it with the best medicines that they thought would help. They fill it with sweet smelling herbs and lavender and medicines that they felt would ward off the infection. It was the best they had. They tried to use it, but the problem was that they never really addressed the solution. It was the best they had, but since they did not know, it was just a superficial washout. And I fear that today we are also walking around like plague doctors, stuffing our bird beaks with technology and quaternary, tertiary level care, thinking that it can wash away the plague of social inequity, but it cannot. You really have to target the problem, and that is and that can only happen if you go into the community and live it for yourself. The programs that we have created over the last 50 years only seeks to create these experiences that transmit more information than we can deliver with a lecture. That lived experience will leave an indelible mark on the psyche of that young student. And that seed may sprout at the end of his undergraduate training. It may sprout at the end of his postgraduate training. It may sprout when he's abroad, or whether he's the head of surgery, or whether he's working at a for-profit corporate. It doesn't matter. But the seed is there and he's aware. And that really is the aim of the secondary hospital program. And we hope that it teaches that tertiary level care is not the panacea for health, that there is tremendous power in the community, much more than what a single doctor or hospital can deliver, that change is a team effort, a community effort, and that a single hospital, including CMC, can do nothing unless there is collaboration across the country, across the government, across private medical industry, across private institutions, and that really is the key towards effecting lasting change. Thank you, and for any questions, I'm happy to take them.
Thank you, Dr. Emmanuel. That was a fantastic talk. I just have a few questions. Actually, there are a lot of questions, it looks like. So the first question is, to avoid jeopardizing the already overburdened workforce at a rural care hospital, how to avoid jeopardizing overburdened care in a rural care hospital when postgraduate students are mobilized to secondary hospital. So when postgraduates are posted there, how to avoid overburdening the already overburdened doctors who are there?
So in our experience, whoever has been whichever hospital has had secondary or had our postgraduates, have said, please send more, because it's more hands-on, it's more work. So thankfully, and I'm sure there are several other coordinators who coordinate district hospital postings at your hospital. We have never had a problem, because they are happy to have more, and they're happy to teach, and there's more hands to see OPD, and there's it's generally not an issue, and I hope it won't be an issue, but generally we have not had a problem with that. But I guess if you're talking about teaching, then yes, probably not. But in terms of hands-on work, most hospitals are happy to have.
Oh, that's great. So this is the question I wanted to ask, but so my question was, what is the student feedback regarding SHP? How did they enjoy it over the years? The question here is, what is the feedback from postgraduates regarding DRP? So if you can give us a bit of both.
Okay, so I will tell you about SHP program. So SHP programs usually, I'm sure there are many students here who have, I can see quite a few who have had SHP postings and who have coordinated a few for as well. So when they go for an SHP posting, these hospitals are usually in different parts of India. You get an institution approved trip to go to these hospitals, and it's a break from work. You have your faculty who's coming along, you visit the place. It's a fantastic holiday for them. It's mandated, but it's a holiday. I can see many people shaking their heads vigorously in approval. But what is interesting for me is the fact that they go with a lot of enthusiasm, and they're like, no, I want to go to this hospital. No, I want to go to this hospital. And there's often an argument saying, which hospital will I go to? What I found particularly revealing was when they would come back to us and when they would present their experiences, every single one of them was visibly changed by that experience, and they would all pick up different aspects. One person would have been touched by the fact that there was nobody to bring the patient from the home to the hospital. The other person would be touched by the fact that there was so much hunger. Every different student was touched by a different aspect. But the important thing was everybody was touched by it. And that really was the key towards this SHP program, that you could deliver seeds of change which was individualized without us having to do anything. All we had to do was get them to have that lived experience, and that was all that we needed. It's a very simple program. It's only a week, and a week is nothing in 4.5 years, but it has such lasting change. And really, if you ask me, what is the metric by which you can measure success of an SHP program? That metric is not looking at the number of doctors who go and work in a secondary hospital. It's a number of lives that have been changed by that experience. And by that metric, I would say we've been very successful. Yeah.
Anything on the PG students' feedback regarding DRP? Do you have any?
Well, okay. So I think there are PGs here who can tell me themselves, but postgraduates, the postgraduate training program right now is a 3-year program, I think, in most specialties. It is a very congested program in itself, and many programs have had trouble staffing their own labor force when you send registrars for 3 months. So that has been a problem that we have faced as well. But most registrars have found it very illuminating, because many of them have studied in an urban center, come to Vellore or come to a large tertiary teaching center, never worked in the government center or a small government center before, and they've come and done a post-graduation here or another similar large center. And this is, for many of them, the first time that they are experiencing this. And it is transformative for many of them. So the feedback is still coming in, and it's positive. There are issues of timing, but overall, I would say it's been positive. But still, I am very, if you ask me, I am very positive about the fact that this is happening, because this is exposure, and all exposure is great exposure. Yeah.
Thank you, Emmanuel. The other question is, what do you think are the barriers that prevent all departments at CMC from executing SHP for their PG trainees?
For their
Postgraduates, yeah.
So I think I can speak for Vellore. I can say that it is the time that we have. We are very dependent on postgraduates for the day-to-day running of our clinical departments. And when you take 3 months out of a hospital program, it's a significant chunk out of 3 years. So you really have to balance how much of time you're going to allocate towards your formal clinical work and how much you're going to allocate towards another additional hospital. My hope is that if we can spend at least about a week or 2 weeks that itself in a targeted center where there is evidence of that hospital doing good work in providing resource appropriate care, I think that would be effective rather than a longer posting. Okay.
There are 2 more questions, but one is more like a suggestion. PGs who worked as JMOs in mission hospitals become investigation dependent after training in CMC Vellore. Can CMC try to send postgraduates for a short deputation to rural hospitals, not necessarily DRP, but for only 4 hours a day?
Yeah, I wish I could do that. Yes.
And the last question is, I think you have already covered this, but I will anyway pose it to you. How will you measure the output or outcomes for this initiative?
Yeah, I think I mentioned it. If you look at it as a metric, then no, it's the metric is not how many doctors are staying in a secondary hospital. That is not the aim of this program. The aim is how many have a seed planted in them that changes their perspective. And that really is all that we want. If I were to say I'm a surgeon, I will not learn anatomy in medical school. That would be very silly. I would be a terrible surgeon. Learning inequity is as important as learning anatomy. You cannot be a good healthcare deliverer if you do not know inequity. And that really is the crux of that. All right. Thank you. And
Thank you, Dr. Emmanuel, for that wonderful talk.
Thank you, Dr. Emmanuel. I would like to request Dr. Ramya to present to him the memento.